A chronic uveitic cataract, which is a complicated cataract, can have this kind of picture. While operating, you find many more challenges. Because of posterior synecdoche, the pupil is all constricted and there is a pupillary membrane in a pupillary area, which is very important to remember and to remove it. Because if you don't remove it, the pupil is not going to expand at all. So remove that membrane, and while removing you might get little bit of bleeding as a hyphema. Now the next challenge is to dilate the pupil and remove the peripheral synecdoche as well. So in this video I have taken a spatula which gone behind the iris to remove the rest of the synecdoche. The anticapsule is retained and the iris is stretched with the two tools diagonally apart. And when I started doing capsular access, I found that the capsule, anticapsule is very fibrous and not giving any entry for the capsular access. So this could be another challenge. So pierce this fibrous capsule with 30 gauge needle or 26 gauge needle, and with the help of vitreous scissors you can cut the fibrous anticapsule in a fashion so that it becomes like a circular rhexis kind of thing. Then later on you can try to remove the soft capsule, but while removing the soft nuclear capsule I found that it could be a rent behind it. So the next challenge was to remove this nuclear fragment or the soft nucleus from the bag itself without disturbing much of the vitreous. So with the help of spatula or a dialer, all the soft nucleus was moved, and you can see with the two instruments, one going behind, another going in front, which can catch hold of this soft nucleus, has been taken into the anterior chamber. Now if we do phaco at this moment, we definitely find that we might disturb the vitreous. So to keep the vitreous away, we have done IOL scaffold. This is one of the good methods where you want to keep a barrier between the two parts of the eye so that the anterior part remains separate from the posterior part, and the posterior part which has got vitreous does not come into the anterior part where you are going to emulsify or going to aspirate the soft nucleus, which being done in this case. Now you can see the whole of the soft nucleus has been aspirated out with the irrigation aspiration, keeping the vitreous back into the posterior segment and not allowing him to come into the anterior part. Later on, with the help of two instruments, the IOL has been placed into the ciliary sulcus with the dialing method. Thereafter, a diluted orocort has been injected and tried to see that was there any vitreous, but fortunately there was no vitreous, and this is how we complete